are guideline-directed medical therapies. You'll see them interchanged. And then we briefly mentioned that the New York Heart Association is kind of what cardiologists gold standard use for that classification based on when they have symptoms, or when your heart failure patients have symptoms, how they're affected, and that's like 1 to 4. And I added the slides to your card yesterday, with the pictures that we didn't have in there before, and then we're going to move on. And now we're talking about things outside of our pillar, outside of our guideline-directed medical therapy, right? Any way you want to look at it. We're talking about things that are going to benefit symptoms, but they are not going to help with mortality, which all of our A, B, D times 3, those pillars, those all help with mortality. So now we're moving into more symptom control, and then we're going to talk about some other agents, and then specifically what we use for an acute decompensated heart failure, thinking ER or inpatient, thinking IV, because as the name implies, acute problem. Then we move away from our 4 pillars. I mean, we still utilize them. However, those are for the chronic heart failure without an acute decompensation. And then I had a good question. We all call heart failure, or in layman's terms, people speak about heart failure and everyone says, oh, they have congestive heart failure. They have congestive heart failure, right? Everybody thinks heart failure equals congestive heart failure. But we'll talk real briefly today that there's actually 4 types. And there is heart failure that is dry, not wet. So not all heart failure is congestive heart failure. And you don't treat them the same. Congestion, backup of fluids, edema, yes, you got to get some kind of diuresis going. But if you don't have congestion and it's more of a problem with the heart itself, that's when you start working on that preload, afterload, vasodilation, those types of things. So just an important thing to keep in mind that the terminology is chronic heart failure or acute decompensated heart failure, and congestive kind of is what we use in layman terms. I mean, it applies to most types you're going to see that are hospitalized, because those patients do come in with the what we'll call the either the warm and wet type, where hypertension and congestion, or either the cold and wet type, or the cold dry type. Wet, dry equals congestion. If it's dry, then it's not congestive heart failure. All right, so first class we're going to talk about, now we're talking about vasodilators. Not in our top 4, right? We already know the A, we hit all of them. ACE, ARB, or an ARNI, which is the new med we introduced yesterday. And then followed by beta blockers, which in heart failure, there's only 3 that we discussed. And obviously decreases mortality, so it's outcome proven medication. And then we move down into our D times 3. The first D is a diuretic, specifically the what class? What's the first diuretic? We're going to use that proven to help with mortality, right? In the potassium sparing class of the MRAs, spironolactone or eplerenone. Spironolactone, you get those hormonal side effects. So if you get that, then you're going to switch it to eplerenone, right? Because if you start to get the gynecomastia, then there's not as many hormonal effects caused by that other MRA, eplerenone. And then we move on with our next D, which was a new drug you just learned yesterday, which is useful in all of our heart failure patients. Anybody remember? Or the class? What's the class? It's the last thing we talked about. SGLT2, right? So those medications are useful in our patients if they can tolerate them, and they're added in to our therapy. And the reason that that's one of the other Ds is the name of the most common one, DAPA, whatever it is. I forget the end of it there. So yeah, DAPA, gliflozin, SGL2 inhibitor. And then we talked about the other diuretics, the non potassium sparing, or the non-mineral corticoid antagonists, or aldosterone antagonists, if you will, with spironolactone. So we talked about the fact that the loops and the thiazides we're going to use to add on, usually if we have more congestion and it's not being handled by the first four that we utilized. But the thiazides and the loops obviously the most efficacious with getting rid of fluid, do they help with mortality in our heart failure patients? Symptom control. And now what we're moving into is just more medications using specific situations for symptom control only. So vasodilators, relax vascular smooth muscle, as the name implies. Decreases preload, so the venous dilation is going to decrease preload to the heart. We're thinking about our equation now with cardiac output, right? And then we're also going to get with the direct vasodilation, we're going to get a arterial dilation, so the afterload's decreased as well. So you're really decreasing cardiac output, cardiac work on both sides of the equation. Useful in acute decompensated heart failure. Dilate quickly, and with other drugs, try to get the fluid off. For an acute issue, not usually your patient's going to be on his 4 pillars or GDMT, his or hers, and then when they have an event, whatever that may be, whether that's an illness or whatever happens, or their body is no longer reacting to their medications properly or not taking them correctly, that compliance issue we talked about, oh, I don't feel like taking those today or for a week, which leads to a month, and then the fluid's backing up and then they crump, right? Acute decompensated heart failure. Those compensatory mechanisms we talked about and the drugs are no longer working. So patient comes into the ER usually or to the hospital, or they're already hospitalized for some reason, and they start crumping with relation to their heart failure. And then we're going to do things to quickly reverse that, which vasodilators are going to relax the vascular smooth muscle, and the agents are there. We'll talk about each one, hydralazine, nitrates, and the nitroprusside. Symptoms and hemodynamics, not mortality. That's your key thing. Decrease preload and afterload, but you're not affecting mortality. There are some uses for select populations in your HFrEF population, which is an ejection fraction below what with heart failure? HFrEF. This is the one our 4 pillars apply to. What's that percentage? 40, right? 40 or below. All right, here's a hydralazine combination, vasodilator. It's hydralazine combined with isosorbide dinitrate, so it's a nitrate, and it's called Vital. It's very, very common. Arterial vasodilation decreases your afterload, and then your venous dilation decreases your preload, and we know from our equation for cardiac output that that's going to decrease the cardiac workload together with the isosorbide dinitrates decreasing venous or preload, and the hydralazine affecting the arteries, decreasing afterload. As we mentioned with hypertension, the guidelines have kind of moved away from our African American population doing better with calcium channel blockers, some other things versus the ACE and the ARBs. And I told you that on your slides it says, if you look back at the memory jogger from our first 2 lectures, that's really kind of out of favor. But in the guidelines for heart failure, the point remains on the slide. So mortality benefit, this is one of the few that have a mortality benefit that isn't in our 4 pillars for self-identified African American patients. And then there's the classes we talked about. We're going to say, if you see that on the exam, once again, classes, I don't expect you to understand or have to diagnose what class. It's extraneous information, but you will see it in the literature. So, but if you see HFrEF, and in an African American population or an African American patient, Vital has been proven to decrease mortality. So you only add that in if they're already on their 4 pillars. If they're already on their 4 pillars of GDMT. For mortality benefits, so you can add in this population yet another medication that's not only symptom control, it is symptom control for all CHF patients. But in a special population, it also helps with mortality, is what the research has shown. Once again, you will see probably on your test questions and exams the NYHA category, and I included it at the end of the lecture that I posted yesterday, and it's on here today, but I don't expect you to categorize. It's pretty straightforward, but we are trying to move away in the pharmacology portion of the didactics to have you guys do any kind of real diagnosing yet, because you're going to get the ologies, right? Matter of fact, you're already in cardiology, correct? Already taken some cardiology courses. So once you get into the ologies, the specifics, they'll give you guidelines if they want you to know the guidelines. The PANTS doesn't really test guidelines. They more so test classes of drugs and when they're useful, just like we're kind of teaching them with the pillars. And it is still guideline-directed medical therapy, but the PANTS isn't going to say, oh, according to the 2025 that was published in February, guidelines for hypertension or for heart failure. But we want you to be familiar with them, but the things that I pulled out, or that myself and Major Hart have pulled out as far as the classes and the specific medications and their benefit and what populations you use them on, it's basically just a summary of those guidelines. So we are using the guidelines, it's just we're not teaching and testing, saying we're doing things only according to this guideline. We're saying out of all the literature out there, what we're teaching you is what's most applicable for the patient based on their diagnosis and comorbidities. But this is one of the special populations you need to know because of the mortality benefit of the vital, that combination hydrolysine and isosorbate dinitrate in African American population with heart failure. So HFrEF with African American, if they've got their 4 on board, also look at adding vital. So moving on, nitroglycerin, we've all heard of it, right? So it's a nitric oxide donor. This is mostly venous dilation. Right, we talked about on just the slide before with the vital, you get venous and you get arterial dilation because of the combination of the 2 drugs. With the nitroglycerin, it's mostly venous dilation, which is decreasing preload or afterload? Preload. It helps to reduce the preload, reduce congestion, pulmonary congestion specifically. So obviously it's going to help with congestive heart failure if you have pulmonary congestion because your heart's not working right. Bless you, because you don't have enough ejection fraction. And as we spoke yesterday, physically what's happened or physiologically what's happened, those fluids stay in your body and they go somewhere if the heart's not pumping them effectively out because that ejection fraction is at 40% or below in HFrEF. Well, the fluid's going to go somewhere. So it's going to go to your extremities, it's going to back up in your lungs, back up around the heart. So nitroglycerin is going to help with the preload portion of that. Usually, as you see for heart failure up on the top left, it's going to be IV, right? It's going to be IV. So we're not doing this as an outpatient medication, telling the patient to go home with their nitro, not this form of nitro, their nitrobid IV. That's going to usually be inpatient. Pulmonary edema and hypertension, acute situations, think IV nitroglycerin. Going to be done in the hospital. It's usually acute decompensated heart failure. They have heart failure, they're on chronic meds, they have a crisis, an infection, some event that causes their heart failure to crump and get out of control. They go into acute decompensated heart failure, and then they come into the office or they go into the ER or the hospital with the usually warm and wet type, which I think you guys have seen it before in parasympathetic, sympathetic, but there's a slide coming up and we'll talk about warm and wet. But just like I mentioned, wet equals congestion. Warm is going to mean that they're perfusing or over-perfusing, so maybe their blood pressure is actually up in the warm type, versus cold is hypoperfusion. You can keep it straight by just thinking about when you don't have good blood flow, you usually have cool extremities, right? So that's the cool type. You don't have enough perfusion. Wet type is congestion, fluids. So then when you see cold, wet, any combination of those two, dry, warm, you kind of know what we're talking about. But pulmonary edema with hypertension, acute decompensated heart failure, usually warm and wet, which means hypertensive and congested. you're going to give IV nitro if it's not contraindicated. We talked about what nitroglycerin can do side effects wise, severe headaches, reflex tachycardia, because you're dilating those vessels so quickly, and then you have a rebound effect where now the heart's going to have to beat faster to try to keep up with the blood flow that's now coming back to the heart or going through the heart because you opened up those vessels. Reflex tachycardia I mentioned. There's a rare complication of methylglionemia. Not super common, but just be mindful of it. I'm probably not going to add that to an exam. It's not that common at all. And then the problem with the IV nitro, it acts quick, but you get, remember we talked about some drugs, they lose their efficacy sometimes very quickly, and that was what term? Tachyphylaxis, right? So this is one of those drugs that we're really talking about a day to 2 days. So it works acutely, but then it kind of loses its efficacy. It stops functioning as well. The body is overcoming that effect. Then you're not getting the venodilation as much as you do in the first couple of days. Okay, the next one is sodium nitroprusside. This is kind of balanced, preload, afterload, arterial and venous dilation. So it's kind of working like that vital, both sides. Your preload and your afterload with venous and arterial dilation. So you can reduce the blood pressure really quickly here. Thus, it's given IV and in the hospital for usually acute decompensated heart failure. So reduces the blood pressure really, really quickly in ADHF or acute decompensated heart failure and any kind of hypertensive emergency really. And we talked about that back in hypertension. Hypertensive emergency, meaning what? What is damaged by your blood pressure? End organ damage versus just elevated systolic hypertension. Sometimes we're using the nitroprusside, sodium nitroprusside IV, also in renal failure, hepatic failure, aortic dissections, all bad things, right? They're all lead you down the road that this is a sick patient in the ER, in the hospital, on the ward. You can get cyanide toxicity with prolonged nitroprusside use. You're not going to be using it that long unless you're in the hospital for a very extended time, at least not the nitropruss, the IV medication of sodium nitroprusside. Reduced preload and afterload kind of balanced, used in emergencies, hypertension emergencies, renal failure, hepatic failure, aortic dissection. All right, now we're going into inotropic agents, which means they decrease or increase the contractility of the heart. Increase it, right? Because we know in heart failure, our patients don't have a good ejection fraction. In HFrEF specifically, it's below 40%, below or equal to 40%. So we need positive ionotropy to be able to get this sometimes large remodeled heart pumping more blood out to our system. So inotropes are going to increase cardiac contractility. They are different than any of the other meds we talked in our our GDMT or our pillars, right? Now we're working on the actual contraction of the heart. So guess what we use it for? Once again, acute decompensated heart failure. Short-term stabilization, think bridge, right? This is chronic patient, prompts out, comes in, they're hospitalized. We're going to give these IV agents to bridge until we can get them back on their pillars or only on their pillars. But we're using any of these short-acting medications to bridge them out of that acute decompensated phase of their heart failure disease back into chronic long-term management of it. We also will use this medication in stage, right? Palliative situations. So just to keep the heart contracting. Someone in hospice, you don't know, I won't get into legality stuff, but basically, in a hospice situation or palliative care where all you're doing is keeping the heart going. Just think short-term rescue for an inotrope, not chronic therapy. You could be on chronic therapy, have an acute decompensation of that, and then you're going to get one of these bridging medications like an inotrope, and the agents are there: DIG, butylamine, and milrinone. Improves hemodynamics, the inotropes do, right? They make the heart pump harder, but it does not increase survival. Using these inotropes in acute decompensated heart failure, cardiogenic shock, or like I said, palliation, palliative therapy. Actually, it's the opposite of mortality. When you stay on these medications for a long time, then it actually increases mortality. So it actually speeds your death if you're a heart failure patient who's now having to stay on these short-acting, in theory, medications for long terms. So chronic use of an inotrope will actually increase mortality, which obviously is the exact opposite of what we're trying to do with every other medication. The kind of caveat is digoxin, right? Digoxin is used long-term. It's the only inotrope that's used chronically. Other than DIG, it's you're thinking that if a patient is on an inotrope for their chronic heart failure, that's the wrong answer, right? This is not long-term therapy and treatment. Inotropes, hospital drugs. They're not in your 4 pillars. DIG specifically, this is the caveat, right, of the inotropes. You will see patients on long-term DIG, not IV, but you'll see patients on long-term digoxin. What it does, inhibits the sodium potassium ATPase pump in the cardiac monocyte cells. So if you're limiting that, you're getting increased intercellular sodium because you're inhibiting that sodium potassium ATA pump or ATPase pump, and you're also increasing intercellular calcium with that sodium calcium exchanger. So what happens? Positive inotropy, more contractility. And you're also going to get some increased vagal tone, which you know from your parasympathetics and sympathetic lecture last semester, that's going to decrease your heart rate. You're going to get slowed AV nodal conduction, i.e. slowed AV conduction slows your heart rate. Increases contractility, decreases heart rate. That's what you need to know about digoxin. It's going to improve symptoms and improve exercise tolerance. That's why you'll see patients on it for long term. Unlike the other inotropes, which is acute decompensation, you need an IV, and we'll get you back on the 4 pillars for chronic treatment to prevent mortality and decrease the progression of the fibrosis and the other negative changes we talked about happening to the heart with long-term heart failure. So it's an add-on agent, not first line. It's not in our 4 pillars. And you only want to start looking at DIG after, whether it's in that acute detoxification, acute decompensation phase in the hospital. They get a bridge with digoxin possibly, but when you're talking about adding it for chronic control for like exercise tolerance and those things, only after you've maximized the pillars, only after you've maximized the GDMT. Once again, it's in that category of symptoms, not survival. That's why it's not our top 4 or our pillars. HFrEF, we can use digoxin in. Obviously, that's why we're discussing it. And you can use it if a patient is remaining symptomatic, even though you've optimized that guideline-directed medical therapy or our 4 pillars. You can add it on for improving that exercise tolerance and improving their ADLs and their exercise capacity. You can also use it if you have concomitant AFib or atrial fibrillation. That's when we'll see digoxin used as well. But it is not recommended for primary heart rate control, like some of the other medicines are for AFib and other arrhythmias. So just think of DIG as secondary, tertiary option. after you've maximized your guideline-directed therapies for heart failure. You have to monitor digoxin levels. So remember, for all the medications we've been discussing since last week, you're looking at kidney functions, BUN, creatinine. We're looking at all of the electrolytes, right? Sodium, potassium, magnesium. In this case, you have to monitor the dig levels themselves, along with the renal function and along with your electrolytes. Because if you get hypokalemia, and we talked about most of the drugs that work in the RAS system, they're going to cause hyperkalemia, right? That's our issue, is monitoring to make sure we don't get too high levels of potassium. I think we said over 5, right? You can't start some of these medications that increase your potassium in your blood if you're hyperkalemic, if you're over 5 already. But other medications we talked about actually decrease your serum potassium. And if you have a decreased potassium, that's going to increase dig toxicity chances, right? So just remember that one. Hypokalemia is going to make digoxin a toxicity concern for your patient. So we monitor the levels, and we're always monitoring our potassium and our sodium. Classic toxicity, and I don't think this is on the slide, but kind of a unique one with dig. Patients will get a green-blue halo or yellowish green halo that they're seeing. So it's always tested. I'm not sure why. I don't know the mechanism. I have to look that up. But dig toxicity leads to a green-yellow halo. Nausea, vomiting is also very classic. And then, like anything that's operating on the heart, arrhythmias. This drug can be so bad that it actually has an antidote. You know, if things have a reversal agent, if scientists have had to go through the effort and the research to figure out how do we reverse this drug, that means that it can be bad juju if that drug is at toxic levels. And that is Digibind. Digoxin immune fab is Digibind. That's the antidote for digoxin toxicity. So unlike a lot of the things where we said be cautious with hyperkalemia, with dig on board, you worry about hypokalemia. With hypokalemia and dig on board, your patient may start seeing those green-yellow halos, nausea, vomiting, and have a heart arrhythmia. Okay, moving on to dobutamine. It's a beta-1 selective agonist. It also has some mild effects on beta-2 and alpha-1. Increases contractility. Good in our heart failure patient, right? It does not release norepinephrine from the nerve terminals. Although it has that beta activity and mild beta-2 and alpha-1 activity, it does not cause an increase in norepinephrine from the nerve terminals. So it has minimal effect on the actual renal receptors. It causes some mild peripheral vasodilation, which is a good thing. Where vasodilation, as we said, decreases our preload. Like most of the other medications that have IV behind them, this is going to be for acute decompensated heart failure. Cold and dry patients. So cold, remember, if you're cold, your extremities are cold, are you perfusing too much or not enough? Not enough. So you're hypotensive usually. And then dry. Does that mean we have congestion or we have decreased congestion? We don't have fluid on as bad backing up on our lungs or around our heart or pitting edema. What is dry? Is that congestion or not congestion? Non-congestion, right? Like I said, there's a quad chart that is really beneficial to help conceptualize that for our visual learners. Low cardiac output, poor perfusion. That's when you're going to see us put on the dobutamine IV. Its effects, tachyphylaxis. 48 to 72 hours later, stops functioning for us. So you can see why most of these medications in the hospital for our crumped acute decompensated heart failure patient, we got to get after it quickly, and the meds are going to wear off. So we got to get them stabilized because after a few days, or in this case, a couple of days, 2 to 3 days, the effects start to decrease due to tachyphylaxis. as you notice, that's more common with these IV drugs. They're short acting, they have shorter half-lives, so our bodies get used to them quicker and overcompensate for them. Short-term bridge therapy. Our chronic patient who crumps and has ADHF goes in with an acute decompensated heart failure. Usually it's going to be our cold and dry patients, i.e. they're not perfusing well, but they're not in congestion. They're not having increased congestion. All right, the next medication, once again, IV, which tells you it's going to be acute decompensated heart failure, and that's milrinone. Different from bubotamine. Inhibits PDE3, phosphodiesterase-3. Prevents the breakdown of C-AMP in cardiac and vascular smooth muscle. So what's happening with that? Because you're preventing the breakdown of C-AMP in the cardiac and smooth muscle, you're actually going to increase contractility because that C-AMP is not being broken down by the milrinone. So increased contractility, vasodilation, decreasing the preload, increased cardiac output, which is, as we know, a good thing if we can increase cardiac output without making the heart pump harder, and further moving down that line of the negative effects of heart failure with the thickening of the walls of the heart and of the arteries and the hypertrophy of the muscular tissue. This is usually your cold and dry patient as well when you use the milrinone. We also use it in patients that are on beta blockers. It tends to do well in those patients if they're already on a beta blocker in an acute decompensated heart failure. Adverse effects, like we mentioned, anything that can raise blood pressure or lower blood pressure, if you use too much of it, it can be a bad thing. So milrinone can cause hypotension. It can also cause arrhythmias. Thrombocytopenia, you guys have had some lab already, right? So you know what thrombocytopenia means, or should, right? Yep. Okay. Not enough thrombocytes being made, right? Not enough thrombocytes in the blood. Like all inotropes, mortality risk is increased for long-term use. Beta blocker and acute decompensated heart failure, think milrinone. If they're already on a beta blocker, which if they're on our 4 tiers, a lot of patients will be, right? Another IV ADHF beneficial drug. All right, here's some key points. We also have at the end of the lecture with the memory jogs, but the treatment key points for CHF and HFrEF specifically is what we are kind of looking at. Big picture goals, right? Improve quality of life. That's why a lot of those patients are put on DIDs, right? So they can have more exercise tolerance. And we talked about yesterday that can you still benefit from exercise if you're in heart failure? Old school thought was, oh, they need rest. They need to take it easy. Don't put any excess stress on the cardiovascular system. Their poor heart's already not working well. No, we can still have positive benefits from exercise. So if we increase exercise tolerance by using some of the medications we talked about, specifically DIDs, right, adding on to our pillars, we can improve quality of life. Also reduce hospitalizations, right? We want to keep them out of acute decompensation events. Reduce mortality, that's our 4 tiers, and then our one special case of demographics, the vital, decreased mortality. We want to slow that progression. We want to slow the harmful effects of the compensatory mechanisms, that arterial wall stiffness, the heart wall stiffness, the huge hypertrophy that we saw in that heart yesterday in the picture. Your body's compensating, but over time, a lot of it due to aldosterone, right? We start to get those negative effects where it gets to be too good a good thing. We don't cure heart failure. And the only way to cure heart failure is get a heart transplant. What we do is slow the disease progression, and then we treat acute decompensations of heart failure with bridging interventions to try to get the patient back to baseline so that we can delay the progression of their heart disease. Big take-home point is GDMT helps with mortality. Everything else Mostly your diuretics, vasodilators, ionotropes are not mortality related, except for the caveats I gave you. They're more symptom control. All right, and we went through the effort of making a slide so you don't have to make your own. Everything on the left, notice, decreases mortality. Through the caveat up for the hydralazine and the isosorbide dinitrate. Notice that one caveat for mortality. Everything else has no real effect on mortality. So that's an exam gold mine right there. But remember, when you see decreased mortality, make sure you look at the top of the slide for CHF, because can the opposite be true in some of the other things we talked about, i.e. hypertension and other disease processes that need diuretics? 100%. There are things that, based on what disease process we're getting after, we can use the same drugs. However, one being good, one could be not so good. So just keep in mind when you're looking at these charts and when you're studying and kind of thinking this through, you got to first start with what does the patient have going on that we need to get after? Is it just their blood pressure? Is their blood pressure and decreased ejection fraction? Is it just fluid and those things are normal? Or are we trying to get after something else different with some of these medications based on their mechanism of action? And once you think about what you're trying to get after, so what the patient has going on, then you got to think about what's going to help with the symptoms for that condition. And then those are what we call the backbone, right? That's our first line backbone for that condition. And then everything else we talk about is usually, these are beneficial in these specific cases. I.e., we talk a lot about when we can't use them, one big one on almost everything, except for a few, like 3 drugs we talked about, right, is pregnancy. A lot of them are contraindicated in pregnancy. We've talked a lot about diabetes. Those are things you need to keep straight. But the point is to make sure that when you're saying, oh, beta blockers are doing our backbone and they're GDMT, yes, they are. For heart failure, are they in our backbone therapy for blood pressure? It depends, right? In some cases, they're worse. So just got to keep in mind what process that you're looking at, what disease process, and keep that straight in symptom relief first, which is in addition to our backbone first line medications. And a lot of that you'll get by just looking at the memory jog slides too. However, that's not everything you're responsible for, just something to anchor your studying on. Okay, yeah. So you need to know mortality benefit versus symptom benefit for heart failure and what classification of drugs. Always think in your layers, right? Your A, your B, for heart failure, your A, your B, D times 3. A bucket, ACE, ARBs, ARNIs, new drug we learned yesterday. B bucket, beta blockers, there's only 3 that we can use in heart failure. We can use more. The 3 that have shown efficacy to decrease mortality are the C and D, right? We talked about it yesterday. And then, you got to make sure you're determining what the second half of that medication is, because there's a couple of different types. And then always think in terms of layers, doing your RAS blockade with bucket A, your beta blockade with bucket B, and then your Ds are your spironolactone or eplerenone, followed by SGLT-2, and then follow that by diuretics for symptom control, which are loops, your strongest, and HCTZ, which is not quite as strong as the loops, but still help with fluid overload. ADHF, we're going to hit it real quick, but I just went over it, right? We went over the medications you're going to use that are not in our, well, some of them are, but mostly it's those medications we talked about that are administered by IV in the hospital. Acute decompensated heart failure, we're trying to decrease symptoms, bridging therapy. Just relieve the congestion, improve perfusion, and you determine which one of those 2 you're trying to do based on is the patient cold, wet, warm, wet, cold, dry, warm, dry. We want to improve perfusion. We want to, in acute decompensated heart failure, basically we're getting after symptom control here. And obviously, above all else, don't give them something that's going to hurt their heart failure. We want to preserve end organ function, do no harm, and then look at their hemodynamic profile and see what can be done for them to address that specific issue. So acute decompensated heart failure is not chronic heart failure management. You don't go into the hospital every 10 days to manage your heart failure. You go into the hospital when you have an acute event, your heart failure has worsened for whatever reason, and then you need a bridging therapy. There is a lot of risk with the drugs and the medications that we discussed that you use in ADHF, and we talked about some of those. Renal injury, as always, in any of the medications we've been talking about, almost all of them also affect enzymes, right? And so electrolytes, depletion. Anytime we are doing something to raise or lower blood pressure or raise blood pressure, it can do too good a job. So you can end up with hypotension or hypertension, usually hypotension from the medications that we're using in heart failure, because you might get too much fluids off in congested patients. Arrhythmia is always concerned with a lot of these medications, so you just need to make sure you're aware of the contraindications and the cautions. You don't continue acute decompensated heart failure IV medications at home, right? So always think for ADHF, you're going to do something to bridge in the hospital, get them back to their chronic treatment with the 4 pillars. So here on the bottom right, you can read through that. It's a little small, but I've got the next slide, actually 2 slides, is a big blow up that kind of shows you how to categorize your heart failure patient that's in ADHF to determine, okay, are they wet? Do we need a diuretic? Are they cold? So we need an ionotrope, right? Because we need more perfusion. So once you think about what's going on with them physically, based on their signs and symptoms and their labs, if needed, then you can determine, okay, what do I give? If they're wet, I need to get the fluid off of them. If they're cold, I need to give them an ionotrope because I need to increase their perfusion. So for ADHF, a lot of times we're going to be treating congestion first. If they're congested, we get the fluid off of them first. And then we're going to look at the perfusion, give them an ionotrope or give them something that's going to increase perfusion to the end organs, to the kidneys, to the brain. Once they're stable, transition back to GDMT. So on the exams, when I say exams, they always pretty much include what you might see here and what you might see in rotation exams, what they put on the pack rat, and then what you're ultimately going to see on the pants, not in the not so distant future for you guys, guys and gals. So you're going to be looking at transition them and then also look at their medication and say, okay, if it's a chronic medication and the patient is acutely unstable, they're in ADHF, well, you want to keep them on their chronic meds, but you got to get after that acute portion, right? Through the ionotropes, the vasodilators, whatever else when they add those 4 pillars. So sometimes the questions will say, you know, patient is on this, what do you do next? And, they start giving you kind of hypoperfusion signs and symptoms and congestion signs and symptoms. Well, the right answer isn't another pillar medication at that point, right? It's not, oh, well, let's add vital. When they're acutely crumping, you want to start thinking about moving towards one of those bridging medications, usually IV in the hospital. So this is a closer look at the acute decompensated heart failure. And it just goes through on the left-hand side on the vertical perfusion, too low on the bottom, moving up the arrow to the positive, and you can see how that's cold versus warm, and the signs are listed there for you. All the acronyms are also listed there at the bottom. There's a lot of them on this slide. Some of them we haven't talked about, but you're probably familiar with. And then across the horizontal axis, you see congestion. So dry on the left and then wet on the right, increased congestion. And so that's how you kind of categorize them, the signs and symptoms. The HJR, if that's too small to read, is hepatojugular reflex. And then DOE is dyspnea on exertion. SOA, swelling of ankles. all those signs of what, right? Congestion. Like we mentioned, that's the sign of congestion with your heart failure. So they're wet. And then P&D is paroxysmal nocturnal dyspnea. On the other side, you'll see prerenal azotemia. Who knows what azotemia is? Y'all had you in nephrology? No, labs haven't come up with it. Basically, it's a buildup of waste prerenal, right? So your kidneys aren't functioning properly, so you get creatinine built up, other nitrogen as waste build up, and you'll see that on the labs, basically due to decreased kidney function, right? Because you're not getting perfused if you have azotemia, and so those creatinine waste, nitrogen waste products are going to build up. So when you don't have enough perfusion, you're not getting rid of those wastes through your kidneys. So that's what that last bullet is down there for the decreased perfusion. Here's another one if you prefer to flip the chart around. Now we just have hyperperfusions on the top and then the congestion the other way. So either way you want to learn it, it's the same things, just presented in a different way. So this is everything we just talked about in a chart. So you can just look at the table. It's just a synopsis, no new information, everything we discussed. Loops aren't on here, but remember we will add a diuretic if someone's congested in addition to these medications. So, but we talked about loops yesterday as a bridging mechanism as well. You don't use it in your patients as your tier, but if they have congestion and too much fluid in their system that's not being improved by our 4 pillars, or they acutely crump ADHF, now they have way too much fluids. If they're in the wet category for ADHF, then loops or thiazide can be added. So just keep that in mind when you talk about treatment of ADHF. Is loops are a thought as well, IV or another diuretic in addition to your pillar of the MRAs or aldosterone antagonists. Let's see here. Just a continuation there. All we spoke about, vasodilators, nitroglycerin, and the sodium nitroprusside. Drug cautions, these are just some overarching. We talked about diabetes. Non-DHP calcium channel blockers, the non-pines, there's only a couple of them, right? What did we say about heart failure and calcium channel blockers? You don't use them. I know there's that one caveat slide that confused a few people because the literature says there is a pine calcium channel blocker that's good, but my caveat was take it with a grain of salt because a lot of studies are showing that it's going to worsen your heart failure. But non-DHPs, that's a never. It's a never because they're acting directly on the heart, right? They're not a pine. The non-DHPs we're using for rate control. So you don't want to start. If your problem is you don't have enough perfusion and enough contractility, then the last thing you want to do is block what little bit of ionotropy the heart has in a heart failure patient. So non-DHP is absolutely contraindicated. There is some literature that says some of the pines you can use, but I will not test you on that caveat. We're just going to say calcium channel blockers, heart failure, no bueno, no good. So a lot of these clinical impacts are going to worsen your systolic dysfunction, increase your symptoms. There is no mortality benefit, especially from the non-DHPs, verapamil and dialtisone. Negative ionotropy effects, exact opposite of what we're trying to do. Then you could put them into acute decompensated heart failure for your heart failure patient that you put on calcium channel blockers, and especially the non-DHPs. And we're moving quickly towards one of those IV medications, or get some positive ionotropy on board. Verapamil, diazepam, and HFrEF, bad thing. Avoid it. For the diabetes, for heart failure, there's really only 2 classes. The TZDs, the thiazidalones, and you see what they both are there on the slide. But that's going to increase sodium and water retention. Well, if you're in congestion, you're already wet. Why would you want to do that? We need to get rid of that fluid in the wet type heart failure. That's going to increase hospitalizations. So the DP4 inhibitors, saxagliptin, that's a type 2 diabetic drug, just associated with increased heart failure, hospitalization, caution in your heart failure patients with a DPP4 inhibitor, saxagliptin. Just know that it's a diabetic drug and it's not good if you have HFrEF because it's going to put you in the hospital, more than likely. On exams, it's usually going to see the TZDs because it's going to worsen your heart failure due to fluid retention. NSAIDs, we beat them up, right? No good in heart failure, no good in hypertension, because the sodium in water is going to be retained due to the diminished diuretic effect. Remember our little picture showing the afferent and the efferent arteriole and where that NSAID is acting to decrease kidney perfusion. And then you got the other things working on efferent arteriole. So together with a lot of these medications with NSAIDs, that's just a no, right? Because you're going to decrease kidney function and increase systemic vascular resistance. So NSAIDs with heart failure pretty much doubles your risk of a hospitalization. Very important to talk to that patient about what they're buying at the HEB off the counter that they may consider safe, which aren't. Corticosteroids, obviously, they're going to increase mineralocorticoid activity, so you're going to hold fluids. That's the side effect of a corticosteroid. Once again, if they're wet type heart failure, that just got worse. Avoid NSAIDs. Sometimes for patients, you can avoid steroids, but avoid them as much as possible and use the lowest dose for the shortest amount of time possible. Heart failure NSAIDs, you're thinking ADHF, right? You're going to decompensate. Class 1 through class 3 antiarrhythmetics, almost all of them, and you're going to get into antiarrhythmetics. I think in block 2. I don't teach that one, but they're all kind of working through negative inotropic effect. Well, in heart failure patients, you already have a negative inotropic effect due to their chronic disease, because we talked about cardiac outputs decreased. So you don't want to use an antiarrhythmic. There are some exceptions that are there: amiodarone, sotalol, and dofetilide. But mostly be cautious with antiarrhythmetics. If your patient has an arrhythmia issue and has heart failure, yes, you're going to maybe have to put something on board, and those are the 3 that have been found through literature to be somewhat beneficial, but still caution, right? And then the last one there, silostazol. It's a PDE3 inhibitor, so don't use it. If this medication is used for intermittent claudication, those patients that with activity, you've heard the classic, they're walking and their legs start hurting, right? Lower extremities start hurting with activity. So that's claudication, so they don't have good blood flow through their extremities. Silostazol, you'll see it used a lot for it, but it is contraindicated in HFrEF because you're going to have decreased blood flow now in the legs and throughout the body. You don't want to be worsening their congestion symptoms by adding that on. Contraindicated, that's a complete contraindication for heart failure patients, is the silostazol. Okay, and the memory jog is hung, and this is a good time to take a 10-minute break. So we'll be back at, let's see, like 3 after. I restarted my I'm not holding on. Yeah, I was. Yeah, I could not. Sorry. But I didn't play the video. I didn't play the video. I'll find out next week. Yeah, I put a video tomorrow.
All right, bro. Take it easy.
Yeah. You can always.
Say yes to.
Always great. But they also have
Exactly, yeah. Oh, so well.
I can tell.
Nice.
But yeah, I'm not.
Oh, I see.
Dude, I just can't keep up with everything. So tired.
Totally realized.
It's however you find with your wedding. I paid for half my wedding and my wife's family does half.
I would say, you're gonna go for it, you take the one that's not.
Like 10 years old.
If you do it with your wedding, the prices are way cheaper.
It's not him you should be talking to, it's his
not
daughter if she's doing her wedding.
It's not too long. It's not too
Trying to figure out how to do algebra.
Wait, she's actually 16. I'll stop us.
Let's go ahead and get started back. Quick housekeeping. On the check on learning yesterday, I had a couple of people question the first one that we asked, and I won't pull it up, but it was basically an ACE and interacts with what? And it was the spironolactone. It didn't say it's contraindicated, interacts. I'll make sure in your exam it's a little more cut and dry, but some people took as interacts as, oh, it's a contraindication. But they're both in our pillars for heart failure. Yes, they are. You just have to be cautious of the potassium, right? So that's what your interaction is. It's not contraindicated. In fact, it's your full pillars. As long as you don't have hyperkalemia, as long as your potassium's not over 5, when you want to start adding those drugs on, then you can't because of the risk of harm. But, you know, contraindications, cautions, absolute contraindications, interactions, those all mean something different. But the correct answer interacts with ACE and the MRA. They both can increase your blood levels of potassium. That doesn't mean they're contraindicated because we know both of those drugs, that's our A bucket and then one of our D3s, right? The only diuretic that decreases mortality in our heart failure patient. So just kind of keep that in mind. I'll try to make sure, or I know on the exam it'll be more cut and dry. An absolute contraindication, or be cautious of whatever, adverse side effect. But just to point that out, absolute, some people were thinking, oh, I'm saying you can't use the spironolactone with, or either of the MRAs or aldosterone antagonists with an ACE. No, you certainly can, but there is an interaction because they both increase your serum potassium Everybody good on that one? And then, I don't know if anybody's looked, but also hung, I don't remember now, 4 or 5 questions from the lecture we just finished in that same area on the card underneath the lectures. There's a whole section that says memory joggers and check on learnings. Those are not if you haven't looked, those are not the check on learnings that we do in class. I think we did a few, but the first lecture in hypertension or that second day, I think we talked about 3 of them, but they're in addition to the check on learnings that are popping up in our lectures. A couple, I think we've had like 2 at this point. These are at the end of the memory jog slides. They are not in the student lectures that are posted or posted before each lecture. So they're only added after because they give you the answers, right? So I don't post them before we have the lecture. That way you can attempt to answer them without going to the answer page, where it then will give you the reasons why the right answer is the most right and while the other 4 choices are wrong or incorrect. So if you haven't checked those out, they're really going to be beneficial in getting used to how the questions are written on your exam. Coming up, 2 weeks from yesterday. So I mentioned before, but the check on learnings, to get you used to pulling out stems that are applicable to the question, to the patient, or what we're trying to get after with the question, they're highlighted or bold. That is not going to be the case on your test. I mean, you guys and gals are sitting in junior semester, so you know we're not highlighting with exclamation points and look here during your exams. But on the check on learnings, I do that just so you can get used to pulling out the pertinent information. Everybody good on that one? All right, we're moving on. We're going to hit angina today, and we'll see where we get. But we're ahead of schedule because we have lecture tomorrow, which is Wednesday. If we don't finish this, we can kind of finish it and then get started right on heme, which is my last point about housekeeping. Heme will be posted this evening. I know some of you like to read ahead, but the heme lecture was probably full of the most distractors. It was like 120 something slides. So I prepared that way down, and I'll get it out to you this evening in case you want to read ahead for tomorrow afternoon. As soon as, however quickly we get through anti-anginal medications, then we'll move into heme tomorrow, and it'll be posted tonight in case you want to read ahead. I just wanted to make sure you weren't spending hours upon hours if you were getting ahead of my lectures, studying all that big giant stack of slide deck when I'm going to pare a lot of that out. So we'll get it out this evening. May get to it tomorrow early. If not, we'll get started wherever we do with heme tomorrow, and then we'll move right in on Thursday to finishing up heme, and then you'll be set up for having all the information and all the checks on learnings, all the memory jogs by the end of the class on Thursday that you will need during that 4-day holiday that you have. And then when we come back on that Tuesday, on your schedule, we're going to have a quick review. It's going to be more Q&A because you have the memory jog slides. Those are already review slides of the key takeaways. But once again, as the disclaimer on every one of those, that is not all the information you're responsible for on an exam, but it is a good anchor point to say, where do I need to put my studying at? So there'll be a review on Tuesday, however long that goes. It may go 10 minutes if that's what you want it to go. It may go an hour, it may go the full 2 hours. But then that Wednesday, which is scheduled for lecture right now, we probably will not have class. We definitely will not have mandatory class. But if someone has questions, I can always meet with you. And that gives you ample time to get ready for your, I think, ortho exam next week. And then you'll have that whole next weekend to prepare for Pharm 2, Block 1 on that Monday. So just for everyone's knowledge as far as what things are looking like, we are ahead of schedule. And we're going to drive on today. However far we get. Then we'll pick up anti-anginal medications tomorrow and then heme to finish everything up. So anti-anginal medications. Pretty straightforward, right? You're having some chest pain, and we got to figure out why. Is it chronic? Is it acute? Is it happen every time you exercise? Is it happening out of nowhere? Is it the classic clutching your chest, having left arm pain radiating to the shoulder, and we need to call the ambulance, and you're having an ST elevation, myocardial infarction? So that whole gamut from I get, some chest pains when I rake the yard, or rake the leaves, or whatever activity that's kind of predictable, all the way up to emergency situation, and you need to go into a lab and get a PCI, you get a stent possibly placed in your heart, or do we go into the OR and you get a cabbage, right? You get a coronary artery bypass graft. So basically we're going to look at what's going on with the patient, how bad is it, what can we do to help it, is it chronic, is it acute, and then you choose your medications based on the mechanism, which is you're going to see, chest pain, anginal patients is going to be forever yours, just like hypertension and kidney disease. You're going to see it on here, then you're going to see it in rotations, then you're going to see it in clinic when you're a certified PA a lot, right? Chest pain could be musculoskeletal, it could be that they're dying. So you've got to figure out where in that gigantic spectrum your patient falls and then how to treat it. So just basically think in terms of what's the heart facing, what's going on with the heart, to why it's screaming that I'm not getting enough oxygen. So we have to either think about reducing oxygen demand, i.e. slowing down the activity and the working of the heart, so decrease the oxygen demand, or we need to get more oxygen in somehow, or both. When I say in, I'm meaning to the heart, specific, right? More blood to the heart, more oxygenated blood. All right, so if you keep it in mind, we're going to, the medications make sense when you think mechanism. These are the heart failure memory jogs, so I won't go into them. They were posted for you, or they'll be posted for you this afternoon, actually, for heart failure, along with the full heme lecture. So ELOs for anti-anginal medications. Basically at the end, what medications, what are the properties, how do we use them, choosing the right drug for the right patient, all the things that we talk about in every lecture, and then how do we give them in an acute situation, and what's the dosing, and then contraindications. If you think select the right drug, identify the right drug, describe the right drug, that lets you know that testing on this and your level of knowledge needs to be at the application level. Take an action, it's a verb, you have to understand what you have to do, not just understand basically what the medication does, but select it, identify it, and then describe what's going to happen. Hey, this is a lot, right? It looks a little intimidating. These are all the different drug classes for anti-anginal medications, but as you go down this list, I think we've talked about almost every one of them. We haven't talked too much about antiplatelets, anticoagulants. We're not going to dig super deep into them because you have an entire lecture, like I said, that's hundreds, well, not anymore, but that was hundreds of slides on heme. And then we'll talk about fibrinolytics and the PDE5 inhibitors, and then statins. So just like the other disease process we talked about, not every patient gets every one of these, right? You have to determine what are the signs and symptoms, what are their comorbidities, to be able to select which one of the class of these medications that they're going to use. But this is a good slide to refer back to when you're knee deep in the slide deck and you go, what class was this that I'm looking at? And you can go back and refer to this. So it's meant more as a study guide to quickly refer back to the different drug classes that we're speaking of for anti-anginal medications. And we'll get right into pathophys. So basically, ischemic heart disease, supply-demand, right? It's a supply-demand mismatch. That imbalance between supply and demand is going to happen because demand's too high, possibly. So tachycardia, high blood pressure, stress. So the demand on the heart's too much, or the supply is too low. Your coronary arteries could be narrowed, which deliver the oxygenated blood to the heart itself. So not getting enough oxygenated blood, not a good thing for the heart. Or vasospasms can decrease, not just blockage in the arteries, but vasospasms decrease blood flow to the heart. Or you can have a big old clot, clotting up an artery. And we're going to get into that, and that's when we start thinking about having to not only add medications, but sometimes we have to go in and do an actual physical intervention, put a balloon in, put a stent in, take a saphenous vein and make a new arterial supply or a new roadway for the blood to feed into the heart itself, to feed oxygenated blood to the heart tissue. So every medicine is going to go back to that same side of the equations, right? How do we decrease the demand, or how do we decrease the supply or increase supply? So never is angina usually present as a single entity, right? Usually we're going to categorize them as stable. What does that mean? It's predictable, it's exertional, you get it, you can predict, if I do this activity for so long, I'm going to get chest pain, and if I sit down and rest for a few minutes, it will kind of go away. That's stable angina. Unstable, that's how it used to be, but now it's not when I walk 2 blocks, it's when I walk 1 block that I'm starting to have anginal or chest pain or angina. So it's becoming more frequent. It hurts more than it used to be, this nagging, chest discomfort, tightness. Now it's really getting my attention more often and giving me stronger angina, so more chest pain. So it's becoming unstable, which now we're thinking of this as an acute coronary syndrome, unless we can rule it out. Like when we talk stable angina, it's kind of predictable, no biggie. When it starts becoming more unstable, we're looking at that becoming an acute coronary syndrome, unless we rule out that you don't have a clot or you don't have a blockage in arterial in the arteries. Silent ischemia, common in diabetics. They don't feel their angina. They don't notice it, decrease nerve reception. So you can see the silent ischemia common in diabetics. It means the heart is getting ischemic, but they really don't have any signs or symptoms. We don't dig much more deep than that on that category. A special classification is called vasospastic or princemetal angina. It's vasospastic, right? So the coronary arteries are spasming. So it's not so much a clot in there, it's actually the vessel itself is spasming, opening and closing, or narrowing and opening. So you're not getting that good blood supply to the heart proper through the coronary vasculature. And you've all had A&P, so you understand what I mean by that. How the heart feeds itself its oxygenated blood supply through the coronary arteries when it branches off the aorta, right? All right, so whether you have stable, unstable, or silent ischemia, or vasospastic, also called princemetal angina, which are those spasms, treatment changes based on which category you are categorized as, based on the type of angina you're experiencing. And that matters with the treatment, right? Because some beta blockers are great for stable angina. We're going to use beta blockers for stable angina. But if you give a beta blocker for vasospastic angina, you might put someone into an ACS or an acute coronary syndrome. So we'll get into the whys and the why nots. So with ischemia, once it gets to be severe, so decreased blood supply to the heart, it gets prolonged, we're going to move into myocardial infarction territory, meaning that portion of the heart musculature is actually potentially going to die. There's going to be an infarct. It's no longer functioning like it's supposed to function. And I know y'all have, I think you're in EKGs right now, so I'm sure y'all have been talking about STEMI, so ST elevation MI, or non-ST elevation MI that you see on the electrocardiogram, which tells you is that an inferior, anterior, posterior lateral infarct. And so I'll leave that to the EKG folks to continue teaching you, but just know that the difference in an in-STEMI, so a non-STEMI, and a STEMI is not just that EKG or ECG trivia, it's the depth of the injury, right? If you get an ST elevation MI, so if you're seeing ST elevation, I think it's on your slide there, when that's starting to go up, you're talking about a deeper level of injury, potential permanent injury to the myocardial tissue or heart muscle. It's full thickness with ST elevation. That is immediate reperfusion, right? We know ST elevation MI is get them to a cath lab if there is one nearby that the EMS can take them to. If not, get them somewhere where they can get some other things on board with the goal of getting them to a cath lab, right? Because you need reperfusion, or else that portion of the heart may die, and it may be such a large infarct that the entire patient may die from it. So in STEMI, non-ST elevation, subendocardial injury, not as deep, still very dangerous. I mean, you can still die from a non-ST elevation MI. So with medication, with an MI, whether that be ST elevated or non-ST elevated, we're still going to then start looking at introducing antiplatelet therapy, anticoagulants, and reperfusion strategies. And we're going to build on that because then tomorrow and Thursday is when we're going to talk all about the heme medications, including those antiplatelets, anticoagulants at a deeper level. Preload, afterload, we've discussed it. We all know that the preload is most affected by volume of blood at the end of the diastolic, so it's in diastolic pressure. So it's that venous return. Afterload is what the ventricles are pumping against. So it's that peripheral vascular resistance. This is just more of an outline of talking about when you start getting clotting of the vessels, just for the visual folks, and kind of what's happening with your anginal symptoms as you see when you move left to right based on the amount of damage that's happening at the arteries or arterioles, kind of what you're going to see in your patient's possible presentation and their complaints about angina as they're moving from better to worse. Blockage of the arteries, which gives them worsening anginal symptoms, now not with exertion but all the time, or that acute crushing substernal pain indicating an MI. So we're going to talk, if I can talk, we're going to talk about chronic stable angina or angina first. It's the foundation. Start here. They have predictable symptoms. These patients, it's usually predicted, they know it's triggered by certain exertions or stress. Every time I mow the lawn, I get chest pain every like 30 minutes and I have to sit down and take a rest and it gets better and I can go for another 30 minutes. Or, I walk my dog and it used to be that I could walk the dog, a mile before having issues, and now it's like 2 blocks. So that predictable anginal pain can be worsening. But with the chronic stable angina, it's usually you can predict, the patients can predict what level of exertion is going to kind of bring their angina on. And usually it gets better with rest, or we'll talk about the importance of those patients having some nitroglycerin for vasodilation at their access so that they can use it when they're having anginal symptoms. And it's reversed by that nitro. We'll talk about why. This is not plaque rupture, right? This is not one of those clots in the arteries rupturing out and going into other locations in the coronary vascular system and causing an MI. This is along that pathway of the picture I just showed you. This is where there's a blockage, but it hasn't dislodged from the inner wall of the vasculature and become an MI or become a thrombus moving throughout the system. It's predictable, it's there. Down the road, it can get more and more and can disrupt, but with chronic stable angina, the difference is we can use long-term pharmacotherapy to treat it. We don't have to talk about going into cath labs and getting a stent or getting a balloon put in, or worst end of that, most invasive, a CABG or a coronary artery bypass. Usually fixed obstruction, predictable ischemia is medication managed and monitored for worsening signs and symptoms. So with chronic stable angina, we're going to have a goal to reduce reduce, decrease how often they're having those symptoms. You know, try to get the patient being able to exert themselves more with less complaints and signs and symptoms of chest pain, less angina. So decrease frequency, and then more than that, we want to prevent them going into an acute coronary syndrome. We want to prevent a heart attack, right? We don't want them to get a thrombus or an MI. We use the ABCDE framework to organize care in this chronic stable angina treatment plan. Aspirin and anti-anginal therapy, beta blockers, and blood pressure. So this is 2 A's, 2 B's, cigarettes and cholesterol, 2 C's, obviously stopping smoking and eating a better diet to decrease the amount of blockage that you're having in those arteries. D is diet and diabetes. So for each letter, there's 2 things that we're looking at. And then E is education and exercise. Those are all of the goals in preventing acute coronary syndrome and decreasing the frequency and prolonging survival by treating chronic stable angina with A, B, C, D, and E. Whether that be the education or the patient counseling, or whether that be talking to them about some better lifestyle choices, or that be actually getting some medications on board. From medication standpoint, what do we want to do? Like with anything, when the heart's an issue, we want to reduce the preload. We want to reduce the afterload so we have an increased cardiac output. And a lot of times that includes decreasing the heart rate and the ionotropy, right? The contractility of the heart, which means lesser oxygen demand, fewer symptoms. Because as we said, angina is basically a mismatch between supply and demand of oxygen. We're asking our heart to utilize too much oxygen, and we don't have enough in our system circulating to the heart to provide it what it needs, so it starts screaming at us in the form of having chest pain or angina. So acute symptom relief versus long-term disease management, right? This is a theme with all of the medications and all of the discussions we've been having for the last 2 weeks. What do we give acute? And then to right now, how do we help this patient to not go down this cascade of worsening or crumping signs and symptoms and going towards increased mortality? And then once we have them stable again, how do we prevent these situations from deteriorating and following that chronic pathway which leads to a higher increase of mortality and morbidity? Chronic management is usually looking at preventing future episodes, as I mentioned. Improving outcomes, you're going to look at beta blockers, CCBs, nitrates, all of which we've already talked about. So chronic, you're looking at long-acting nitrates, not those nitrates that you use in the hospital for an acute decompensation heart failure, but a long-acting nitrate. And then we're going to look at antiplatelets, statins, and ACE inhibitors. We've talked about everything but the antiplatelets and statins pretty much. So when you're thinking about a question stem, what do I give right now to get through this patient through their acute issue, or what do I give long-term to prevent the natural progression of this disease process? And when we talk acute, there's only a few things that we look at for stopping the pain now, right? We're going to give them rest, stop doing what you're doing that's giving you chest pain, decrease that demand of oxygen from the heart. Fast-acting nitrates, like I said, most of these patients we're going to make sure, should all of them that are having any anginal symptoms, a fast-acting nitrate that they can give themselves, and we give them some education on how often they can use it before they need to call EMS. And then we start looking at chronic to prevent future. And then when we're talking about chronic stable, obviously there's only a couple of things I mentioned there for acute relief: rest and take this nitrite. But then if it gets worse and we start getting into an acute coronary syndrome, that's called EMS, or you're headed to the hospital, and then we'll talk about the medications that we use for that, which a lot of you are familiar with. So for the chronic stable ischemic heart disease patient, beta blocker, beta blocker, beta blocker. First line is your go-to, beta blocker, period, chronic unstable angina. It decreases the heart rate. Remember the beta 1 receptors on the heart? Decreases contractility. It lowers the myocardial oxygen demand, and it improves survival post-MI. If tolerated, every patient that has an acute coronary event or an MI is leaving on a beta blocker, and for how long? Well, probably forever, but many years. It's been proven to decrease mortality. And we want to improve that survival post-MI so we don't have it again. We're also going to look at calcium channel blockers and nitrates. They're not wrong. CCBs and nitrates are not wrong in angina treatment for chronic stable angina. However, that's an add-on. That's not our backbone. Once again, beta blockers, period, in this category of angina. You can't start looking at the CCBs and other nitrates if your patient cannot tolerate beta blockers. Obviously, beta blockers block or antagonize beta 1 receptors in the heart. Slow heart rate, less contraction, lower blood pressure. You are taking the demand off the heart, right? They suppress renin, the beta blockers do. We've talked about the ROS, or the renin-angiotensin-aldosterone system, ad nauseum. So you should know what suppressing that renin will do in the ROS cascade. Back to our very first hour together. That's why beta blockers are so useful in cardiovascular disease. All the above mentioned. One caveat, or I guess more of a be aware, like anything, if we decrease the heart rate or lower the blood pressure, it can go and become too good of a good thing, and then we're over into causing problems with the medications that we're using. So you only treat with a beta blocker to a resting heart rate of about 55 to 60. You start getting below that 55 number, you might want to start thinking about your beta blocker, because we're getting down now to where the heart is way too chilled out, right? We want to take the work required on the heart off of it, decrease that oxygen demand, but we don't want to completely shut down the ionotropy of the heart or the heart rate or the contractility force of the heart. So 55 to 60 is kind of your titration level 2 with the beta blockers with angina patients. So for the beta blockers, the patients that do best with it, if they have that effort-induced angina that we spoke of, predictable, right? If they're having symptoms more than once a day, if they've had an MI, right? I said, unless absolutely contraindicated, if you have an MI or an ACS, acute coronary syndrome event, you're leaving on a beta blocker. Lots of times, the beta blocker is going to be combined with a nitrate, because the beta blocker can blunt reflex tachycardia that nitrates can cause. The nitrates, as we mentioned, potent vasodilators, and they work pretty quickly, and then you get reflex tachycardia, but the beta 1 receptor blockade will then kind of quell that follow-on effect of tachycardia caused by the nitrate quickly dilating the vasculature and then clamping back down, and then you get a reflex tachycardia. Well, if you take a beta blocker with that nitrate, the beta blocker is helping to control that tachycardia because it's decreasing heart rate. Very few beta blockers, one of the few classes of drugs that are on decreasing, that's going to give you a mortality benefit or decrease mortality long term. So remember, this is kind of rehashing another couple of lectures. You have your selective beta 1 blockers on the heart, then you've got the representative of that class, atenolol, metoprolol, and that's what's usually preferred, right, is the beta 1 selective. If there's not a whole lot of other comorbidities around, then use something that's only going to work on the heart, because that's the problem with chronic unstable angina or chronic stable angina. Non-selective is your propanol, notalol, higher risk in asthma. Why? Because you're counteracting the effects of that quick-acting beta agonist that your patient with asthma usually has to take to dilate the vasculature for the beta receptors in the lungs proper. And then you got your mixed alpha 1 and beta, that's the carvedilol, labetalol. That's useful with heart failure and hypertension. We mentioned those in both of those lectures. But that's your mixed A1 and your beta. Beta 1 selective, obviously preferred. And then the ISA agents that we discussed, the acebutolol and the pendolol, so that intrinsic sympathetic symptomatic activity, those are the two from it. You're going to avoid that class of beta blockers with angina. They don't suppress the heart rate as well as the other classes. And actually with angina, the ISA beta blockers can worsen it. So just remember the ISA classification of beta blockers is a no-go for heart failure, for angina treatment. Absolute or major contraindications, we said, bradycardia, heart rate below 55, let's not drop it too much more, right? So once you get down to that titration level, the heart rate's at like 55, you don't want to keep adding on beta blockers or increasing their dosage. If you have a heart block, contraindicated, right? Because now you're affecting the inotropy of the heart with a beta blocker. Well, the electrical signal activity of the heart is already blockaded for some reason, so you don't want to further lead them to a complete block of the heart or an acute coronary syndrome when their heart quits beating due to a heart blockade made worse. And so either you're getting the atrial and ventricular discord where they're not beating together, or you actually just decrease systole altogether. So be careful with heart blocks and beta blockers. Decompensated heart failure, we mentioned just 30 minutes ago. We have to be careful with the decompensated or acute decompensated heart failure with the beta blockers. Caution in diabetics, because a lot of times the beta blocker we talked about will affect their blood sugars. So sometimes the diabetics may not feel the hypoglycemia that's going to be brought on with the beta blockers potentially. Abrupt withdrawal of a beta blocker is dangerous. It can lead to the things that you are trying to prevent. Worsening angina, MI, sudden cardiac death. If you have ischemic heart disease, do not suddenly stop beta blockers. Titrate them down if you're going to change them. And you see big red box, big capitals, avoid the ISAs. In angina, and on the top right of your slide, for chronic stable angina, contraindications. That 55, we talked about the PR interval, or leading to letting you determine that you actually have a heart block, or if you have that acute decompensated or chronic decompensated heart failure or asthma. Those are going to be your contraindications. We talked about them. No new information here. Decompensated heart failure, second and third degree heart block, bradycardia under 55. Key cautions of the diabetics and an abrupt withdrawal. Otherwise, we have talked about everything else in this slide with beta blockers. It's just in a different color than the first time we talked about it on the slide in a different lecture. So for calcium channel blockers, we talked about them. We talked about what they do. They block the L-type calcium channel, which leads to vasodilation. Reduce myocardial oxygen demand. So far, so good, right? That's what we're looking for with our chronic stable angina patients. But the non-DHPs, the non-pines, remember, we use those for arrhythmia issues. So they function more on the heart. So the big distinction is for the non-DHPs, the verapamil and the altazam, there's only two that we've ever talked about, they act directly on the myocardium, slowing the heart rate. And they're a negative ionotrope. And then the DHPs, the pines, amlodipine, right, being kind of the classic, they're vasodilators. Minimal effect on the heart rate. Can get some reflex tachycardia from the pines. So remember that the non-DHPs rate control, the DHPs vasodilators. Important difference there. And we've talked about it in hypertension and we talked about it in heart failure. So calcium channel blockers are used when beta blockers aren't tolerated. It's always a beta blocker unless they can't take it, right? Or they're on a beta blocker and symptoms persist, we're still in the category of chronic stable angina, right? Or if you have vasospastic angina, that Prince metal angina, that's calcium channel blocker, first line. That's the exception to our beta blocker rule. Prince metal or vasospastic angina, directly, the calcium channel blockers will directly relax coronary artery spasm. They do not improve survival, the calcium channel blockers, for our chronic stable angina patients. They just control symptoms, right? We mentioned it, and you've seen the slide before, and you've seen the table before. The non-DHPs, calcium channel blockers, and their effects on the heart. The heart rate, the inotropy or the contractility, and this is the same chart that we looked at in hypertension and heart failure. So avoid the non-DHPs in heart failure, we reduce, so HFrEF. We mentioned it, nothing new. Too slow of a heart rate, don't use a non-DHP. If it's below 55, you're going to make it worse. Non-DHPs affect the heart rhythm. A heart block, already probably leading you towards a rhythm and an arrhythmia. So avoid non-DHPs and heart block. Verapamil and dialtazam increase DIG levels. Remember we talked about DIG, it's so bad that it has a reversal agent, nausea, vomiting. What about with the eye? What do you get? Green, yellow halos, right? And arrhythmias. So be careful if the patient's on DIG and they have chronic stable angina and you're thinking a non-DHP CCB. Combining that non-DHP CCBs with the beta blockers is severe bradycardia. You're going below 55. So just remember where they work, the DHPs versus the non-DHPs, and what you're trying to get after. So if you do too much of a good thing by having a beta blocker on board and then you add a non-DHP, you're probably below that target titration level of a 55 beats per minute heart rate. So the DHPs, when we're going to use those? Additional blood pressure control, we know that because we all have studied the first 2 lectures on hypertension. So we know that we can add them in addition to our diuretics, the DHPs, to help control blood pressure for hypertension. We also can use the DHPs for symptom control in chronic stable angina, as we're doing, as we mentioned already here. Prince metals angina, DHPs, number 1, that's the backbone versus the beta blockers. So the only caveat is to avoid short-acting DHPs for angina. If it says immediate release, nifedipine, avoid it. Because it's rapid vasodilation, and that can cause severe reflex tachycardia. Which then makes everything that you're trying to get after worse. So you're going to have an increased oxygen demand, and you're going to have increased mortality, MI due to worsened ischemia. So with the non-DHPs, avoid the IRs, right? I'm sorry, with the DHPs. So the nifedipine's the classic one you'll see, IR. Just too many effects from its rapid action. It's actually counter effects, right? So avoid short action DHPs. Nifedipine, IR for angina, no go. The main DHPs you're going to use, amlodipine, safe in chronic stable angina. Felidipine, similar role, less common. You're going to see amlodipine mostly. And then nifedipine, but the XL, right? Extended release, not the immediate release, which causes the reflex tachycardia or rapid vasodilation that worsens ischemia and can lead to an MI. So basically, if you see CAD and a PINE CCB, avoid IR nifedipine. Okay, adverse effects. DHP, calcium channel blockers, peripheral edema, flushing, headache, dizziness, same stuff we talked about with the same class for a different issue, which was hypertension. For the non-DHPs, bradycardia, because they affect directly on the heart, worsening heart failure, and we talked about those signs and symptoms and adverse effects in hypertension and heart failure. Key interaction, beta blockers, verapamil or dialazine, right? We mentioned it already. Complete heart block, potentially, from having those non-DHPs affecting the heart, the myocytes, and then having the beta blocker on board, which we already talked about, decreasing ionotropy, decreasing heart rate, all the things that we need to equal out that supply-demand mismatch that we see with angina patients. Okay, so the next class is the nitrates. We'll start here on the nitrates and we'll finish up in about 5 minutes, and then we'll pick it back up tomorrow, because then it should only take us about 20-30 minutes to finish up nitrates tomorrow, and we can jump on heme for the first hour, the second hour, and then wherever we get to finish up on Thursday. So nitrates, we talked about them with heart failure, right? They're very important in angina. We're not just talking about them as second line and rescue drugs if you have acute decompensative heart failure. Like for angina, very important drugs. They generate nitric oxide. The nitrates as a class do. They dilate the coronary arteries. Relaxes smooth muscle by that nitric oxide acting on the vascular smooth muscle. It's venodilation. It dilates veins. What does that do? Decreases preload, just like everything that is a vasodilator does. It decreases wall stress in the left ventricles, decreases myocardial oxygen demand, i.e. the nitrates, the coronary dilators, are helping with our supply-demand mismatch of oxygen from the work that the heart's being asked to do versus the blood and oxygenated blood return that it's receiving, and thus it helps with it not screaming and giving you pain because it's deprived of oxygen, so angina is better. So the nitrates decrease the wall stress, decrease oxygen demand, and then we reduce that preload. That's the main reason that it decreases anginal pain, is because we're decreasing the preload by venous dilation or coronary dilation. Several settings: acute angina, acute pain, use a nitrate. A lot of times that's going to be your sublingual tablets, or it's going to be a spray. If your patient has angina, whatever type, they should be leaving their visit with you with a nitrate for rescue reasons. Just like, think of it as like your patient with allergies, severe to bee stings is going to have an EpiPen with them, right? In this case, if you have a history of angina, you need a fast-acting, rapid-acting nitrate, usually in the form of sublingual or of a spray. It's mandatory. That is a malpractice if your angina patient is not going home with something to use if they start having that chest pain. Long actors, nitrate class, are add-ons for chronic stable angina. And then unstable or variant angina is going to a lot of times require IV. There's a theme here. If the word unstable or acute is in the description of what disease process you're talking about, you're usually talking about in the hospital, not in your outpatient clinic, not in your aid station or whatever area you're working in. It's usually the hospital. So every angina patient has a PRN sublingual nitroglycerin available, period, unless there's an absolute contraindication to it. So nitrates have a significant first pass metabolism, which is why the oral formulations require much higher doses. Nitrates can be sublingual or transdermal, and that will bypass that first rate metabolism. So you don't have to use as high concentrations of the nitrates if it's getting in quickly without the first pass metabolism, and it's going more quickly through the transdermal or the sublingual route. They have rapid onset, predictable effect of vasodilation. 1 to 3 minutes for that sublingual nitro. So if you're hurting, your patient's hurting, having angina after that exertion or whatever brought it on, they're having that predictable angina or unpredictable if it's acute, they get the sublingual nitrate in, usually, or the spray, a couple of minutes. They're like, thank goodness I had this. Thank goodness my provider gave me this to use. It's predictable, 1 to 3 minutes. You can get nitrate tolerance, and it happens pretty quickly. So if you're on those IV meds, and I think we mentioned it in the last lecture, tachyphylaxis, right? Pretty quickly, within 24 hours, if you have continuous exposure, there's going to be a counter action to where through tachyphylaxis, you're no longer getting the violation of the dilation effect of the nitrates. That's when you're on continuous. That's why if your patient is on continuous nitrates, continuous actually means 12 hours. There has to be about a 12-hour drug-free or nitrate drug-free period in a 24-hour period to where the medication continues to work. Or else, the first 24 hours they're using whatever nitrate, long-term nitrate that you gave them. If they take it continuously without 12 hours between dosing, or if it's a patch, they don't go 12 hours with it off, then or if they're in the hospital, if they don't go 12 hours without the medication on board through an IV, then tachyphylaxis sets in and it's no longer doing anything. So to prevent the tolerance or the tachyphylaxis, 12 hours off every 24 hours. Actually, I think literature is 10 to 12 hours off, but it's kind of easier to think in 24 hours, half of that time you need not be on a nitrate, or else it's going to lose its efficacy. And those are especially important, like I said, in the transdermal patches, because the patient could put it on and forget and leave it on. And guess what? That first day they do that for a 24-hour period, now it's not really going to help them with angina anymore. Also important with oral long-acting nitrates. So it's a dosing issue, right? You got to make sure the patient doesn't say, well, if one was good, I'm not supposed to take it again till tomorrow, I'll just go ahead and pop another one. I was having some angina. Well, now it has no effect. This basically exam-wise, if your patient's on a patch, we present you with a patient on a patch, and they have angina despite your treatment, start thinking about, are they developing a tolerance, or is tachyphylaxis set in because they've had too much nitrate exposure? So an adherence issue, like we talked about a bit with hypertension. So I think we're at a good stopping point for today. We'll finish this up rather quickly tomorrow. This lecture, as far as angina lecture, will be posted today, even though we're going to finish tomorrow.